I request Dr. Ajay Kirtane from Presbyterian, New York, to carry on an analysis of the Freedom trial. Thank you, Dr. Ajay.
Thanks so much. So I'll actually start, and I'll discuss a little bit of the surgical side as well. It is an interventional meeting, but I think it's important to speak about surgery. And my talk was crafted as a counterpoint, but I think I can speak about both PCI and surgery and how we make the decisions for our patients. So, you know, this fight of PCI versus Cabbage is one that we often are depicted as at war with each other and really debating one versus the other. But at least, you know, I can tell you in the United States, what we really are fighting now is the press and many people who say that we're trying to do too many procedures. And so this was actually in Newsweek, which is, as you know, a major publication in the United States. And the whole point of this was that unnecessary procedures are being done, we're doing too much, and if patients say no and opt for medical therapy, that can save their life. And I would say that that's true except for the fact if you have prognostically important disease. And when we talk about multivessel disease, in the United States, there's conventional wisdom now that coronary disease that's stable cannot kill you. You're only treating patients for symptoms. And I would say that's not true, especially if you have prognostic disease, and that typically is multivessel. And so in defense of Cabbage and bypass surgery, some of the studies that actually support revascularization of patients to prevent mortality actually all come from the surgical literature. And so it's important to mention that there's a lot of good data, old data, showing that Cabbage is beneficial over medical therapy, and this is important to not forget. And the key question when we ask ourselves of whether PCI is equivalent or similar to surgery relates to the fact that are we able to extrapolate the data of bypass surgery to our PCI patients, considering that PCI has been improving. So we'll start first with symptoms. I think it's pretty clear that both bypass surgery and PCI can reduce symptoms overall. This is early data from the UK demonstrating that if patients met criteria for revascularization, the reduction in angina was very similar among patients who were treated with PCI or Cabbage. Similarly, in a randomized setting, in the Syntax trial, what one can see is, interestingly, that quality of life outcomes are equivalent. So patients with severe multivessel disease randomized in a clinical trial have very similar quality of life outcomes, and in fact, PCI is associated with an early improvement because it's less invasive. And that's important to remember given the fact that in Syntax, a fair number of the PCI-treated patients did not actually undergo complete revascularization. So what about the Freedom trial? This data has actually been published in Circulation, and again, it's really important to note that out to 3 years, there's actually a numeric benefit in favor of PCI compared to surgery. Now, if you continue out to 5 years, quality of life starts to deteriorate, and I'll show you why based upon some of the mortality and MI data from this trial. But if you speak specifically about symptoms, we do very well with PCI compared to Cabbage, particularly for patients with multivessel disease and particularly for those who undergo complete revascularization. So now let's talk about prognosis. I think it's clear that PCI can improve symptoms, but can we improve prognosis with patients with multivessel disease? And I think the answer here is yet undetermined. But I will show you that this is actually a study that recently was done and published in the European Heart Journal that looked at patients that had CT angiograms. And overall, it was a low-risk patient population. But actually, if you look at this patient population, as you had more and more progressive disease, for instance, 3-vessel disease, there was actually a benefit to revascularization compared to medical therapy. And this was a mixed population of PCI and surgery. But if you actually do a meta-analysis, and this is published by Shripal Bangalore, one of my colleagues at NYU, and others in his group, randomized trials of PCI versus medical therapy, there is a reduction in spontaneous MI events. So if you think about all the randomized trial data, the MI as a whole is equivalent. The reason for that is we cause periprocedural MIs, but then there's a reduction in spontaneous MIs over the follow-up period, and this is statistically significant on the order of about 25% reduction. Similarly, if one were to look at cardiovascular mortality, not just all-cause mortality, but cardiovascular mortality, although it's not significant, there's a similar reduction in cardiovascular mortality seen with PCI compared to medical therapy. And so this is something somewhat novel in the sense that we generally feel that we don't change outcomes relative to medical therapy. But I would posit that if you take a high-risk cohort of patients, such as those with multivessel disease, and revascularize them safely, irrespective of how you do it, you can actually potentially improve prognosis as well. So then the real question becomes, if you need to revascularize, and I think for multivessel or prognostically important disease we do, which procedure would you rather have? And so we'll go to the randomized trial data. We'll first speak about syntax. As you know, this was a randomized trial randomizing patients with three-vessel disease and also left main disease to PCI versus surgery. If you look at the outcomes here overall, they actually favor Cabbage over the Taxus stent. But if you look at them specifically based upon anatomic complexity, a slightly different story emerges where the outcomes do appear to be relatively similar among patients in low to intermediate syntax score. Now this is just the three-vessel disease subset, which looks worse, by the way, than left main disease, and I can explain why a little bit later. And in the high-risk cohort, it seems that it would not make any sense to do PCI in these patients with the Taxus stent. Similarly, in the FREEDOM trial, and this is a trial of diabetic patients with multivessel disease randomized to surgery versus PCI with either the Cypher or Taxus stent, up front, there was actually a benefit to PCI because PCI is less invasive. But over the follow-up period, particularly from 3 years and out, the data really favor Cabbage. And so many people have looked at this data and said there's no way we should be doing PCI in these patients. I don't think that's a reasonable stance to take when you speak to a patient who was talking about a very different procedure, but I think based upon the data, we have to be circumspect, and before we recommend PCI, we need to have a good reason for doing it. And that's why I generally, if I have somebody with multivessel disease who's a diabetic, will stop, take the patient off the table, and actually use the heart team approach. This is the mortality data, which did favor bypass surgery over PCI, particularly splitting after about 2.5 years, and myocardial infarction clearly favoring bypass surgery over PCI with a basic doubling of the rate. And this is not all periprocedural. If you look here, all the action in these curves occurs outside of the procedure for the most part. So this is something we really have to be careful of, and I'll talk about why that is in a second. Now, if you look at the syntax score stratification, it seems that there's no difference based upon syntax score in this trial. And so this is another reason why proponents of Cabbage have actually touted this data as saying it doesn't matter who you are, if you're diabetic and you have multivessel disease, you ought to have Cabbage over PCI. So what is great about Cabbage? I think it clearly is the gold standard at present for multivessel disease. Certainly here in India, where it's less expensive than a multivessel PCI with BVS and the like, it's something that really needs to be spoken to about the patients. And there's several benefits to it. One, it's one-stop shopping. It has a lasting procedure, and the data is in its favor. It's complete. You can do complete revascularization at once, compliance and adherence are less of an issue, and the surgical risk assessment by risk calculators like STS, Euroscore, and the like is actually very reliable, and you can tell the patients what to expect going in. But the real question here is, so why do many patients and physicians still favor PCI? And the surgeons will often say, well, that's because you have them on the table, you did the diagnostic, and then you dictate what you do, and you're doing PCI in these patients. But I would say that's not the only reason. And the biggest reason is that these are two very, very different procedures. Bypass surgery on the left and PCI on the right. They're so different that people would obviously prefer the less invasive procedure if you could demonstrate somewhat equivalent outcomes. Now, we actually can demonstrate superior outcomes with respect to some endpoints that are very important to patients, like stroke. And if you look at a meta-analysis of 8 randomized trials at 30 days, there's clearly a reduction in stroke with PCI compared to bypass surgery among patients with multivessel disease. And by the way, similar results were also seen in the FREEDOM trial. And that's why I have a real problem with people who say all diabetics with multivessel disease should have surgery. The question I have is, well, do you talk to the patients about stroke? Because that's an important endpoint for patients when they're considering a decision between two therapies. The other thing, and this is really important, is that PCI is different now than it was in the syntax trial and in the FREEDOM trial. So first, have all known and very familiar with the data from FAME, which demonstrates that if you actually revascularize lesions that are hemodynamically significant, but leave those that are not alone, you can actually use less stents and actually still have better outcomes than if you treated everything just based upon the angiogram. So an FFR-guided approach can reduce these periprocedural events, and even not just periprocedurally, but late MI events that potentially can occur with excessive stenting. Now, similarly, if you actually look at functional severity of disease in patients with multivessel disease, as was also shown in the FAME trial, it turns out that the angiogram is not necessarily the best test. And actually, the FAME investigators have demonstrated that you can downgrade your syntax score by doing a multivessel FFR and only revascularizing or aiming to revascularize lesions that are functionally significant. Now, what about the freedom data? And if you look at the data here, this is the MI curves again, and you can see that they all separate out to this point here, and they get very ugly for PCI out to here. Well, why is this? Why did this occur? Well, they haven't presented their stent thrombosis data yet, but if you look at the syntax trial, in the multivessel disease cohort, actually the overall cohort, there is a rate of stent thrombosis at 5 years of 10.4%. And I will tell you, that's just frankly unacceptable. If it were you or me on the table and I were to tell you that you'd have a 10.4% chance of a stent thrombosis if I did multivessel PCI, most of us would say, please don't do it. So it shows you that these stents, as were used in this trial, had an unacceptable rate of stent thrombosis, and the question is, can we do better than this? And actually, if you look at data with second generation or newer generation drug-eluting stents, there's a clear reduction in stent thrombosis. So we think that we can improve upon the results that were observed by more judicious stenting, not stenting things that don't need to be stented, but also using newer stents that are perhaps safer compared to the old ones. So just in conclusion, I think, key questions to ask in patients with multivessel disease, I think there's not a right answer. There's not one therapy versus the other, but you really need to ask how good a job can you or your surgeon really do? What do the targets look like? How complete can you actually revascularize? Is the disease very diffuse? And what are my skills? If I feel that I have to do a complex rotablation case that I'm not comfortable doing, then maybe I ought to favor surgery. On the other hand, if my surgeon is not that good and can only do a single bypass graft that's an arterial conduit and everything else is going to be veins and the veins are bad with bad targets, well, clearly surgery is not going to be a good option. Now, what are the goals of therapy? Is it a mortality benefit or a symptom relief or less invasive procedure? And the patient, their frailty and other things like that have to be taken into account. Other things that you want to make sure you'd ask, can the patient adhere to DAPT? What's the surgical risk? And are there other things that go on? I will point out that the heart team approach is currently a class 1C indication in the guidelines. And I would say, again, if you have a patient with complex multivessel disease, do take them off the table and make the discussion and have them speak to a surgeon so we can actually adequately do this with informed consent. It's hard to tell somebody that you just had PCI and the randomized trial data shows a doubling of the MI rate because I did PCI compared to surgery. It's much easier if you took them off the table. I'll also caution you to remember that within the trials themselves, the results are averaged across patients who get PCI and Cabbage. And this is a slide from Syntax demonstrating that at some sites there was an unacceptably high rate of surgical MACE, and at other sites there was an unacceptably high rate of PCI-related MACE. This would be an example of that. No surgical MACE and a 50% rate of PCI-related MACE. Know which site you are. If you have terrible outcomes or your group has terrible outcomes, well, you shouldn't be doing PCI, you should be doing surgery. If your surgeon has terrible outcomes, well, they shouldn't be sending the patient to surgery. You should be doing PCI. And so these things are really important because randomized trials average treatment effects across all the patients and sites that are in the trial, whereas individual patients and individual physicians can have variable outcomes based upon their skill and the patient sitting in front of you. So I think in conclusion, and I hope I could summarize both the surgical and the PCI data because our prior speaker wasn't here, I think in 2013, remember that multivessel disease is a high risk and prognostically important patient scenario. It's the least stable subtype of stable ischemic heart disease, and certainly in the United States where many of us think of stable disease as something that doesn't kill you, that's not true with multivessel disease. It can actually kill you, so you need to think about revascularization of these patients. I think regional functional assessments like FFR definitely trump angiography, and they also trump stress testing, which is not as good at detecting all the regions of ischemia. It's better at just detecting the worst area of ischemia. So do think about doing things like FFR. I think for true multivessel disease, you have to take patients off the table, assess the options with them, and really discuss it with them in general. And then finally, I think in the end, honest patient selection attuned to objective patient preference will generally dictate the best and most appropriate care. Thanks.
Thanks, Ajay. That was an excellent presentation. I think you spoke for surgery as well, because we don't have Dr. Gopinath over here. But I'd like to put a few, points to you. I just want to ask you, the second commonest graft by all over the world is a saphenous vein graft today, still. That's a point that needs to be considered, because it's not total arterial revascularization that occurs. So in that scenario, what do you really look at, especially in a setup where now we have functional flow, you have the FFR available to you, and very often you can downgrade the syntax score. I think that makes a huge difference, and with the newer stents. So what's your perspective on that?
Yeah, I mean, I think actually the prospective data of downgrading syntax score is not there right now, and that's why the FAME-3 trial is going to be done to actually look at this. And in general, I think it makes sense. Why would you put a graft, particularly a vein graft, on a lesion that's not hemodynamically significant? But that having been said, that's been what has been done in the studies, and that's been demonstrated to be superior. So I think we have to be a little cautious with that. But I completely agree. I mean, I will really make the surgeon tell me, and the surgeon can tell me whatever they want, and in the operating room they do whatever they want. But I really stress, are you going to use bilateral memories? Because actually, radial conduits are used, but they're not necessarily as good as a Lima or a Rima for that matter. And so in general, with a bilateral arterial conduit, if they can do that, I do think that there's going to be a benefit. But we have surgeons that train in PCI in our cath lab, and they will routinely, if you ask them at the end of the day, if they have a right coronary lesion, would they prefer a drug-eluting stent or a saphenous vein graft? And they would even say we'd prefer a drug-eluting stent.
The other area which has now come, to the interventional cardiologist is the left main, which was, totally outside the domain of the interventional cardiologist earlier. The left main with a single vessel where the syntax score is low is another area where I think the graphs are showing that even the 3-year data, 5-year data show pretty good results. Your perspective on that? Yeah,
absolutely. I think the most enticing data from syntax is definitely the left main data, but it was a small subset of patients overall. And that's why there are 2 big randomized trials ongoing right now, the Excel trial and the Noble trial in Europe, that will hopefully answer this question. But I do think that in this patient population that has left main disease, easily approachable by PCI, without significant complex multivessel disease, this might be the sweet spot for PCI. And again, remember, the left main is prognostically important as well. And so this is another way that we can demonstrate that revascularization with PCI makes sense, not just from a symptom perspective, but also from prognostic.
Yeah. I think you have a case presentation right now?
Yeah. Is there time? Is that okay?
Yeah, there's time for the case presentation.
So what I will do, open this. So this is actually a case of multivessel disease. It's a little bit different than the one in the program, but I think it illustrates some points. And this is a diabetic patient with multivessel disease that I had the opportunity to treat. A 60-year-old gentleman who is diabetic, referred for routine screening to a cardiologist, and states that he was asymptomatic. Now, interestingly, this issue of asymptomatic status is a very controversial one, but I always think it's important to assess the history better, because there are patients who sit on the couch all day and watch TV who may be quote-unquote asymptomatic, but then if you tell them if they walk up a flight of stairs, they get very out of breath, that's different. They're not truly asymptomatic. And so, in general, he had a sedentary lifestyle, and he said that he got out of breath if he exerted himself, and says he's out of shape. So is he truly asymptomatic? It's hard to assess from this type of situation. His medical regimen, he was on aspirin, he was on a beta blocker, was not well controlled, he was on diabetic medications as well, and his lipids certainly were not at control for a diabetic patient. He actually was sent by his referring doctor for an exercise perfusion study, only went 5 minutes on a Bruce protocol. Remember, he's 60 years old, and diffuse ST depression was noted. The EF was 52%, and he had several defects, both inferolateral and anterolateral as well. And I will point out that, again, when we assess these patients, one is the history, how symptomatic are they? 2, most people, at least in the States, only look at the results of the nuclear stress test. They don't look at how far they exercise or things like that. In this case, 5 minutes of exercise in a 60-year-old man, to me, is clearly not normal, and that information needs to be integrated when we consider whether the patient is truly asymptomatic or symptomatic. So one question would be, what would you do now? And I think, in general, my clear statement here is this patient needs to have an angiogram. In the United States, the current recommendations are actually somewhat controversial, and they may say that we ought to treat the patient with medications first, see how he does. He's asymptomatic. There's no reason to actually do an angiogram. And many of you may know that our ex-president George Bush last week had a stent placed. He was asymptomatic, and there was a huge controversy in the United States, even among interventionalists, saying he never should have been taken to the cath lab in the first place. In this scenario, a 60-year-old gentleman with 5 minutes of exercise tolerance and multiple defects, I think you have to do a diagnostic angiogram. You don't have to treat him depending on what you see, but you need to make sure he doesn't have left main, for instance, because that's prognostically important. So this is actually what the diagnostic angiogram showed, and he had multivessel disease. He has complex disease in the circumflex, in the prox mid area, as well as in this branching OM system. And then he's got a significant lesion in the prox LAD, and I think you can appreciate the aneurysmal post-stenotic dilatation here, right where a diagonal branch comes off in the LAD. Here is another view of that, and you can see this is somewhat complex here, and the right looks basically preserved. The ventriculogram was also done demonstrating largely normal EF. There's a little bit of a hang up here, but the echo had demonstrated a normal ejection fraction at that time. So then I think the questions are, what should be done next? And I'll put these options up here. Maybe do you all want to comment on what your thoughts are, or should I? What do you think?
I think you can go ahead and when we...
Okay, so basically, I think there's many things to talk about. I do think that he's symptomatic. He's not truly asymptomatic, and I think with this type of disease, I would favor a revascularization-based approach. So the issue is that he really didn't want to have surgery done, and he actually opted to undergo PCI. He was taken off the table, though, to have this discussion. As I mentioned earlier, he's diabetic with multivessel disease. And I think that revascularization was thought to be preferred over medical therapy, but the main issue here was that aneurysmal segment of the LAD. And again, there are anatomic considerations that need to be taken into account when you make these decisions. And what I had sort of told him is I said, look, if we can't adequately wire the diagonal and protect that big diagonal branch, then PCI is not a great option for you, because I don't want to cause a big periprocedural MI during the case. And so actually when we proceeded with this, it was actually very difficult to get a wire into the diagonal. And so the question is, you need to think about all this before you go in. And if you can't do it and you can't protect it, then maybe you should stop at that point. I wouldn't advocate ballooning and proceeding. And so in this case, what we actually did is with the use of a hydrophilic wire, I was actually able to get around the aneurysm into the diagonal branch and then successfully wire both diagonals, protect them, and do a stent of the LAD. We then, at that point, opted for a complete revascularization strategy and ultimately treated the circumflex as well. But you could ask, was PCI necessary? Certainly, many of my conservative colleagues would say PCI of the circumflex might not be necessary, but I actually opted to do it because he had ischemia in that territory based upon stress testing. So overall, he's done well. He remains on long-term dual antiplatelet therapy that was ascertained prior to the revascularization. Symptoms are improved. He continues to remain overweight, like many of our patients, and lipids and blood pressure were better controlled. That's sort of the case that I wanted to show you, but I do think some of these considerations are important to think about. Number one, take the patient off the table. Number two, think about what you really can do, how safe it would be to do it, and is that the right option for the patient?
That's a very good case you showed. A few points, would you, in these kind of situations, would you, look at other scores like the Euro score, all those other issues before you, decide between surgery and intervention?
Yeah, so in our hospital, when we take patients off the table, we will have the surgeon come and see the patient. They actually, as part of their assessment, it's an electronic record, and part of their surgical assessment, they calculate an STS score. So they'll tell the patient what that would be at that time.
Because I think sometimes that also makes a difference towards intervention or bypass surgery.
Absolutely.
Especially if you have very high-risk patients for surgery, and even though intervention looks difficult, I think they get away better with an intervention sometimes when surgical risks are unacceptable.
Yeah, and I think one thing, by the way, that is not well recognized is if you look in the Syntax trial itself at the early 30-day outcomes, they actually are no different with PCI compared to surgery. And that's really, really surprising to me, because I would always think that surgery is going to have a higher upfront mortality. And it, I think, shows you that sometimes when you tackle a disease that you shouldn't be tackling with PCI, you will have an early mortality, and that you don't want to do that. So in general, with things like STS, that's a 30-day score, and if you see that's going to be 8%, most patients don't want to take a, close to 1 in 10 chance of dying within the first 30 days, and that really informs how you treat patients.
Do you all talk to patients about cognitive function after surgery?
We do, and the surgeons don't do a great job of doing that. We do, but I don't overly stress it, because I have a hard time. We can talk about that. We do talk about stroke as well, but it's hard to really, garner exactly how much dysfunction they're going to have. And I think the biggest problem that we have is it's hard to predict who's going to get it. And, I've seen patients that are like 60 years old, they look great, and then they have horrendous neurocognitive function post. I've seen 90-year-olds or 80-year-olds who you think are going to do terribly, and they come out the same as they did before, so it's hard.
What's the percentage of off-pump surgery in your center?
It varies depending on our surgeon. There's some surgeons who are 100%, some surgeons who are 0%, and it kind of depends on who you send to.
Okay. I think, are there anything from the audience that, yes?
My question is to Dr. Kitane, who practices in the US. How difficult your practice has become in making a decision on the basis of the evidence versus the concerns about lawsuits, the media, the insurance in today's world?
I think we definitely feel it. I think that when it comes to the patient sitting in front of you, it actually, if you spend the time, you look them in the eye, and you're a nice person, and and you're doing it for the right reason, that tends to not be an issue. But I think more globally, I can tell you just really quickly, I had a case of a diabetic individual who came to me for a second opinion. He was being seen by a non-invasive cardiologist, and he was diabetic with a strong family history of coronary disease, youngish, very obese, and had an EF of 30 with severe MR, and came to see a new EF of 30. And was told by the cardiologist he didn't need a catheterization, didn't need any further testing, all he needed was medical therapy. He had a stress test that was abnormal as well, by the way. And he came to see me, and my immediate reaction with this guy, who, by the way, when we cathed him, had pulmonary artery pressures in the 60s, multivessel disease, and severe MR, and ultimately went to Cabbage AVR. But my initial reaction was, how many other patients is this cardiologist seeing and under-treating like this? And so here in India, there's a problem that they don't even see the cardiologist because they can't get access to care. But for us, there are many people who are just not even coming to get the diagnostic study because of fear of doing unnecessary procedures. And so that is what I think affects the most. As far as lawsuits and things like that, I think as long as you're doing things for the right reasons, in general, it tends to be okay.
I think this point is taken, and this debate with surgery versus PCI will carry on.